Hello. Hi, my name is Felice Darko. Welcome back to my YouTube channel. And today I would like to share with you a presentation that I've done for the International Conjoined Twins Day in Riyadh, Saudi Arabia, in 2024. So this is a special presentation because actually there is a push from the international community to try to get together the expertise related to conjoined twins, these very rare cases, and I was very, very happy to be invited to be part of this initiative. This conference and this day was organized by the KS Relief, and I will put the link for this organization, humanitarian organization based in Saudi, in the description. Before starting, I have to say that I was lucky enough to be part of the group of doctors in Great Ormond Street Hospital in London that manage these children, because actually when I came to Gosh 10 years ago, to Great Ormond Street 10 years ago, I barely know the existence of conjoined twins from medical school. While, as you can see here, the experience, especially from the neurosurgeons and craniofacial teams in separating Craniopagus twins is quite vast. We, as a hospital, these are the cases we have either operated, separated, or we gave an opinion upon, and there is a foundation, charity foundation called Gemini, which is whose purpose is gathering fund in order to allow these families to come in UK and to receive the surgical treatment. And these are the countries that were involved, where the children are coming from. So there is a link between Great Ormond Street Hospital and several countries. And now with this initiative, there will be a stronger link between Great Ormond Street Hospital, Saudi Arabia, and other countries that were gathered together to discuss this rare pathology. So let me start with some notes related to epidemiology of the Craniopagus twins. So Craniopagus twins are these conjoined twins that are joined by their head, and there are several classifications and several anatomical presentation of this malformation, what we call a malformation. Conjoined twins in general are less than 2 per 100,000 births, and of those, only 1 to 6% are Craniopagus twins. Of those, only 1/4 reach the point where surgical separation can be considered, and this means that these Craniopagus twins are extremely rare. So from a radiological point of view, what does it mean? Well, this means that actually there are no standardized CT or MRI protocols, and we have standardized protocol for a lot of things. I was involved in writing up a standardized MRI protocol for head and neck diseases in children, for achondroplasia, and there are standardized protocol for neuro-oncology, and so on. But this rare problem does not have anything or very little written up in the literature. And also there are very few centers with previous expertise. So there are very few friends you can call and ask for advice. And as I said, no standardized protocol means no guidelines, even in the technical approach to this, or the practicalities related to scan to children that are joined together. So because there was not such bulk of literature available, and because we had a lot of cases, we decided to write down this protocol, and this is the paper, and we joined our effort with another center in Europe, the Bambino Gesu Hospital, Pediatric Hospital in Rome. They also had some previous experiences in separate and conjoined twins. So we gathered together our experience, and we decided to write down these protocols. But what guided us? What was the philosophy? Well, it's actually we try to see how we can answer the surgical question. There is a quote. This is a part of our surgical team, but this is a quote that I love a lot, and says, "A man only learns in two ways: only by reading, and the other is one is by reading, and the other by association with smarter people." And because there, as I said before, there is nothing we could read about that. We decided to ask our smart surgeons what they need. And so I would like to guide you in the next 20 minutes in the journey of scanning and prepare the surgical planning of these children. And I learned three important lessons. The first one is taking care of practicalities. The scanning preparation is as important and complex as the imaging acquisition itself, because these are unique cases, and the system is not designed to scan children that are joined together. So two scanners, two scans in one moment. And the first thing is identifying a lead nurse or radiographer. This is Jess, our chief MRI radiographer, together with the plating specialist and one of our patients. And this nurse or radiographer needs to coordinate the complexity of scanning to one set of twins. And what are this problem? Remember, we are scanning two patients simultaneously, and this means two anesthetic teams, two sets of MRI compatible monitoring, long acquisition time with dedicated MRI and CT, and surface MRI coil, because the normal head coils are not designed to scan two heads that are joined together. Finally, this is Trevi Fountain in summer is full of people that want to stay close to the fountain, and something similar happens in the MRI room, because or city room, because everybody wants to be involved in this very rare case, very unique cases. So you need to limit the access because this can create a serious problem in the scan. So these are practical points, but these are so important that without that we cannot proceed. So the second lesson I learned is that you need standardization, but also every set is unique. And how we provided this standardization? First of all, protocol standardization. This is the table from our paper that that shows the CT and MRI protocols. As far as the CT is concerned, normally, at least in the pre-op, stage, because then the separation is done in multiple stage. So the first CT post-contrast needs to be done, injected first one twin and the other twin next, so we can see the dynamic of contrast, because the vascularization is sometimes shared, as I will show you in a few minutes. But it's important to note that we added, especially on MRI, the possibility of optional sequences. And we really are looking forward for further collaboration, especially with the medical team in Riyadh, to try to improve these protocols that we saw as a starting point, not an arrival point. But it's important that the goals are clear in mind, and the goals are covering both hands properly and answer specific surgical questions. On a technical note, if you have dual source CT, this will be much better, because you will need to distinguish very well between bone vessels, and afterwards separating and surgical material. So that's very important technical point. The second thing is clarity in the report. These children, as we will see, are extremely, they shows and present with extremely complicated anatomy. And of course, this anatomy is require complicated reports. So we put a template, an example of report template, and these are the first two sections, introduction and the skull appearances, that will guide you in reporting these children properly. So clarity is very important together with standardization. Finally, what is the third lesson I learned? Is that we need to answer specific surgical questions. And what are the surgical questions? So I asked Professor Owaser Jeelani, is our craniofacial and neurosurgeon in chief, and he told me, well, I need to know how the bones look like, and then how the brain look like. Where is the dura separating the brains? This is extremely important for them to know. And finally, how the vessels look like. So let me show you each of how we try to answer each of these questions in a practical and effective way. As I said, first of all, you need the MRI and CT. This is the classification of Stone and Goodrich from a paper from by Goldman et al. From USA, and I invite you to read also this paper that shows very interesting cases. But the first thing is how the bone looks like. But the bone are very similar to what we see clinically. So this orientation showed in these drawings, and we use the CT. The CT, as you can see, shows very well the location of the different bones and the angulation of one twins as opposed to the other twins. And for instance, we can give this information here showing which bone of twin one, let's say twin one is the one below, is in contact with which bone of the twin above. But also, if you see here, you can also show, and this is very scan done when the children were very young because the metopic suture is still open, you can say to the surgeon, which suture, like the coronal suture here of twin 2, is in contact with what looks like the fontanelle, anterior fontanelle of twin 1, going, continuing in the metopic suture. So you have the not only the bones, but also suture and fontanelle anatomy very well described. And these are vertical twins. These are angular twins. You can see in this specific case, the left frontal bone of T1 is in direct continuity with the T2, twin 2. T1 and T2 stands for twin 1 and twin 2. So all these nuances related to the bony anatomy can be seen on CT. What about the brain? The problem with the brain is that the brain location does not follow exactly the bony location. And this is because, of course, the skull is a rigid content, while the brain can be deformed by the angulation of one head as opposed to the other head. And so, as you can see in these specific cases, you can see the deformation of the lobes, and you can also see where the lobes are clearly separated. Probably here there is dura, but I will speak about the dura problems in a bit. And also here where the bones are interdigitating with the brains. So the two brains are interdigitated among each other. And these are the areas where you can have small bridges of bony tissue. So you can see here, there is gray matter connecting the two lobes, one belonging to twin 1, the other to twin 2. So we are looking for small bony bridges, and this is very important. And also it's important to use 3D sequences, like in this case, we had a para-axial that can show again the digitation between the lobes at that level where the dura is not visualized and where there is a higher surgical risk during the separation. So in my Pearl is used a 3D sequence because, as you can see here, you can have in the 3D sequences, you can, of course, create a multi-directional reformats that allows us to track down the small parenchymal bridges between the brain. This is another example here from our paper with this brain connected between the two. Now, one thing that is very important is that the angular twins can have, as opposed to the vertical conjoined Craniopagus twins, more wider areas of bridging tissue, sometimes making the separation impossible. This is a case, again, from literature, is a CT, but you can see these diencephalic bridges that will pose a very important ethical problems. In these meetings, there was a discussion about the ethics of separating twins. Sometimes you can save the life only of one twin. Some other times is technically possible, but ethically not right to separate these twins. So there are also ethical aspects that are very, very important. Finally, advanced techniques. This is again from literature. We did put DTI as, and we did DTI in a couple of sets, and we put DTI as an optional sequence, but you need to understand that the color coding will be really confusing because of the deformation in space of the brain parenchyma, and so you can use the DTI, but probably 3D sequences are still the best to show the connecting tissue. We use the DTI to try to track down the main tracks, like the corticospinal tracks, for instance, in order to tell the surgeon where the risk of permanent damage and eloquent areas are where in the brain pre-separation. Another important question is, where is the dura? And the dura is as important as the brain to be visualized, because where there is no dura, there is huge surgical problem. So this is dura. You can see clear separation between the brain and the dura is shown here as a small relatively hyperintense line in T1. But where there is no dura, like here, there are possible bridges, and again this digitation between the brains. So the brain are very close to each other. 3D-T2 shows the dura very well as an hypointense line, and you can use this again to this 3D-T2 sequences to segment the dura and put the dura in a virtual reality space. And I will show you a video in the next slides, but the 3D-T2 is as important as the 3D-T1. Now, this is a case from Goldman. It's an older 3D-T1, so the resolution is not the best, but they could not see the dura at that level. However, they couldn't demonstrate, despite the high resolution, bridging tissue between the two brains. However, in the operation, they show in their paper, there can be, so the surgeon found actually some small bridging tissue. So this is still possible, even if we cannot see, and we need to look for the dura. Again, the neurosurgeon needs to know where the dura is absent. So this is a 3D virtual reality reformat. I just want to show you the two brain, the surface of the two brain in contact with each other here. And then you can literally enter the brain and see the different vessels. And we color-coded the vessels. This was done by one of our collaborators, Luke Smith. We color-coded the vessels in different color. So you can see in pink the vessels related to twin 1, and then if you go here, the craniotomy view in light blue, the vessels of the twin 2, and then in between here you can see the shared vessel in dark blue. So this gives you an idea of where the shared vessels are, but also we did segment slice by slice the dura. So where we could see the dura separating the brain, we color coded in green. Yellow and red, yellow where we were not sure, and red is where the dura was absent. So this area of interface between the two brain is the dangerous space for the neurosurgeon, and this gives you exact 3D appearances and location or where the absent dura is. So the virtual reality that we use really works not only for us, but also when we have cases somewhere else in the world to kind of go through the cases together with the colleagues on the other side of the world. And this has been used practically, it's not only for publication. So I think this is very important. Finally, we need to know where the vessels are. Are they shared or not? And this is the problem. We have two kinds of vessels. We have to look for arteries and veins. Let's start with the arteries. First things, if there is shared perfusion and if there are large vessels shared. What we realized is that when we inject one child or another child, and we delay the CTA enough, we could see perfusion-like images, like in these cases, that let's say, allow us to see which part of the brain parenchyma of one twin is perfused when injecting the other twins. So this is what we described as shared perfusion. And in red here, you can see basically the limit, the separation between the brains. And this is actually very important because you don't need fancy perfusion technique that are difficult to make work. And especially if you have ASL or if you want to use perfusion, contrast perfusion, these children are very small, so you have a lot of problems. ASL, for instance, is a problem because of the orientation of the brains and also because of the age of the patient. So do you need to use advanced perfusion technique? In our opinion, not, at least for the clinical side of it. You just need a good CTA, and this is the example on a vertical craniopagus, and this is in angular craniopagus. Again, look at the perfused brain of the other twins. So it's very important you inject the first one twin and the other twin, and you see the shared perfusion. You can also see large arteries going from one side to the other. This is the middle cerebral artery of one twins going in another twins in a recent set that was separated by the Great Ormond Street team. So this is very important. In other cases, exactly the same techniques, but here the other twin's brain is pristine, so there is no shared perfusion. So perfusion techniques are not needed, you need a CTA. What about the veins? The veins are always shared to some extent. Why? Because embryologically, the dura and the venous sinuses, they are very much linked. So we have shared dura in between the Craniopagus twins and also shared veins. So we need to tell the shared sinuses and if there is this entity called circumferential venous sinus. In order to do so, this is so important for the surgeon, more so than the arteries, that we need to do all the possible techniques. So we use MRV, MR venography, CTV, and sometimes angiography. Look at the MRV. This is angular twins. You can have small venous bridge shared or the entire posterior aspect of the sagittal sinus shared. So this is much more difficult. This is a vertical craniopagus, and you can see the entire posterior sagittal sinus is going from one twin to another. Important for the surgeon to know, but also the famous circumferential venous sinus. And I like MRI venography because it gives you the entire view of the venous sinuses in both the heads. This is again on MIP, the circumferential venous sinuses sitting in between the two brains. And when this is clearly visible, the surgeon needs to know at what point to separate it. Very, very important. We also use, this again, circumferential venous sinus. We also use, and this is the schematic drawing of the circumferential venous sinus. Be aware, sometimes you cannot see it, so this can be a bit of a problem. We can also use the MP-RAGE post-contrast T1. Now, the 3D T1 MP-RAGE, we learn to use it whenever we want to have a CTV-like appearances on MRI. We learn to use it, for instance, in children with venous sinus thrombosis because being a gradient, the sinuses are full of contrast. So you can see here these small veins going from one twin to another. So the high resolution of the 3D is important for small shared veins. CT venography also very important. You can do injecting one twin like we did here to see the contrast going from the twin below to the twin above. So it gives you a dynamic contrast, and sometimes angiography that can show arteries and veins connected to connecting one brain to another, like in these cases, small occipital arteries going into the other twin. So basically, we need to use all the possible techniques, but we need to keep thinking. Sometimes after the first separation, we know already the dynamic of how the contrast goes from one twin to another. And what we want to do, and this is a slight courtesy from Dr. Manzoor Ahmed, we want to do after the injection twin 1 and twin 2, we can inject both twin together in order to have better resolution. We do not advise to do that in the pre-op alone, in the pre-op planning, because as I said, you need the dynamic of information about the dynamic of contrast or actually blood flow. So this is very, very nice, and you see the nice images and the nice reformats. So constant communication with other colleagues and sharing the expertise is paramount. Now, we did use a lot of 3D modeling and like in this case, and also virtual reality. The 3D modeling, like in this case, clearly showed the circumferential sinus sitting between the two brains, and it is very, very interesting and give the surgeon a much more real life kind of appearances of the anatomical changes. So in conclusion, what is the imaging approach to Craniopagus twins that we studied? Preparation is complex. Be prepared. You need to start, as I said, from very, very thoughtful planning and coordination between the department. This can take a lot of time. So the whole hospital rotates around these two children for all morning or a whole day sometimes. Answer the surgical question: bone, brain, dura, and vessels. And this is something, this is a picture I love to use to conclude my complex talk. So this is from my time at the university in south of Italy, in Naples. The street signs say hospital, highway, and I learned from these cases that, like these street signs, these cases are complicated, baffling, and very, very confusing. So remember, it takes a village, and I really need to thank all the people that were involved in this in this operation. This is the link, the QR code for the Gemini Foundation. And I would like to thank Professor Owaser Jeelani in particular, together with my colleague of the neuroradiology team, and the other, like Professor Mankad, the other neurosurgeon, like Professor Thompson, Mr. Zubair Tahir, and so on, Dulu, that really helped me in understanding more the complexity of these cases. I put the link again, the useful links at the back of my. So in the notes of this talk, please get in touch if you want to know more. Thank you very much for your attention, and see you soon.